Okay, and Dr. Hinia, what do you think, professor in Department of Psychology and Center for Refugee Studies at York University? Okay. Conducts community-based research on interventions that can strengthen social and institutional relationships to improve health and well-being.
Sure.
Much of her work focuses on communities and situations of social conflict and forced displacement. She's conducted this work in Canada, the Democratic Republic of Congo, India, Liberia, Nepal, Rwanda, Sierra Leone, and South Africa.
Sure. I don't know if you need that.
Okay. What is your preference on what we keep and what we...
Like MEP, I think shorter is better.
Okay, perfect. So then I'll... Okay, perfect. Then I think what is your talk going to focus
Social
on?
determinants of refugee health.
Which community of refugees are you?
I'll talk about one study with Syrian refugees, but
Okay.
I'm also using some pan-Canadian data.
Okay, so I'll leave in the 5-year longitudinal study on Syrian.
That's the one I'm going to be talking about, actually. So yeah.
Perfect. Okay, so I'll just start that. And Dr. Hinia is the past president of the Canadian Association for Refugee and Forced Migration Studies.
Okay.
Perfect.
That's great.
And does anyone have any comments or things they would like to add as like disclaimers or introductions?
Disclaimer.
Trigger warnings.
I do have a disclaimer in my slide saying that I have no conflict of interest, but I'm willing to take a few if anyone's donating it.
I have lots of conflicts, but lots of interests.
Yeah, sure.
Ooh, that's a good one.
So, Camille, I think everybody's hearing us as we're talking now, aren't they? Or
sorry, yeah, because Josephine wasn't able to come on earlier. So Josephine, when you're ready to start, I think you can jump in with the intros.
Okay, perfect. Sounds great. Well, it's that time. So thank you all for coming. And while we're gathering virtually today, we acknowledge that each of us is on the traditional territory of many nations across Turtle Island. We broadcast from Toronto, the traditional territory of the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. Today it is the home to many diverse First Nations, Inuit, and Métis peoples. We offer this acknowledgement as a stepping stone towards honoring the traditional occupants, a testimony to the oppression faced by Indigenous peoples, and our commitment to creating dialogues aimed at addressing such systemic injustice. So welcome again. My name is Josephine Bywaters, and I'm a youth member of the Pegasus Institute. At Pegasus, our mission is to reduce disparities, inequities, and social injustices and promote global health through the lens of peace and sustainability. We're very grateful to be able to serve our community and for the continued support of our partners. Because of their generous support, we can present this program for free. These include Wilfrid Laurier University, University of Waterloo, the Social Sciences and Humanities Research Council, and the IPPNW Canada. The virtual seminar being presented today is one of many to come out of the Pegasus conference. While our goal is primarily educational, we hope to connect people for action, including research, policy, and advocacy. I want to encourage everyone to join in the conversation for our event today. We want to make this as engaging, as interactive as possible. It's not every day that you have access to these amazing experts. Our presenters will be taking questions directly from our live audience, so you can ask your questions using the Q&A feature at the bottom of your Zoom screen, should be on the bottom right. Now, the theme for this first presentation is practice and advocacy for the vulnerable. And I'm very excited to welcome Dr. Meb Rashid, Medical Director of Crossroads Clinic, a medical clinic that serves refugees arriving in Toronto. He is also the co-founder of the Canadian Doctors for Refugee Care and was on the steering committee of the CCIRH. And he is on staff at the Women's College Hospital in Toronto, and he's an assistant professor with the Department of Family and Community Medicine at the University of Toronto. He's worked with refugees for 20 years. We're honored to hear from him today. Please welcome Dr. Rashid.
Thank you so much. No one knows what that CCIRH is, but it's a Canadian Collaboration on Immigrant and Refugee Health, really an organization that's spearheaded by a family doctor named Kevin Potty, who helped to develop guidelines for the assessment of immigrants and refugees. So thank you very much for that introduction, Josephine. It's a pleasure to be here today. What I really would like to do is I just want to sort of set the stage to make sure that we have a sense of what's happening in terms of refugee migration in Canada and across the world. And I'll speak about a little bit of a hodgepodge of different issues that I thought may be instructive to people. And then I look forward to Michaela's presentation, where she's going to be really giving us a little bit more detail about some of the research that's going on in terms of identifying what has guided refugees through their acculturation process. So I consider myself the opening act, but really look forward to her talk. So I'm going to speak to you today. First of all, I have no conflict of interest to declare. I want to start by taking you back to an event in the not so remote past here in Canada. It was the late 1970s, and there was incursions by China into the northern part of Vietnam. In response, the Vietnamese government decided to expel all ethnic Chinese from the country. Many took the opportunity to try to leave Vietnam. And if you remember, there was chaos going on in Cambodia and Laos. Over 2 million people were moving in Southeast Asia at that point in time. And although most were moving overland, the issue really came to the attention of the West when we saw pictures like this, these overcrowded, rickety boats in the shark-infested, pirate-infested waters of the South China Sea. Now, the Canadian government at that time, seeing the response of Canadians to this tragedy, put out a call saying for every one family that was going to be sponsored by a Canadian citizen, the government would match it. Much to their surprise, 40,000 mostly Vietnamese refugees were sponsored by Canadian citizens. And the government, their math being what it is, said, okay, we'll take 10,000, and eventually were shamed into taking 20,000. So 60,000 mostly Vietnamese refugees arrived here in Canada in the late 1970s, really the early 80s. And I draw your attention to this migration because, one, it's still one of the largest migrations in contemporary Canadian history of refugees to Canada. But two, I would argue that it's one of the best studied. And through the works of Dr. Morley Beiser, who's in Toronto now, but was in British Columbia at the time, he followed over 1,000 refugees for over 10 years. And what did he find? Well, interestingly, he found rates of employment were higher in refugees than people who were Canadian born. And rates of mental health issues were actually lower in this refugee population than people who are Canadian born. Now, when I first ran into this literature many years ago, I must say this didn't seem intuitive. But the more I thought about it, this is exactly what I was seeing. People needed help when they arrived, but when they hit the ground, once they hit the ground, they really hit the ground running. So as healthcare workers, as people working in communities where refugees are resettled, people in the settlement sector, I think this really becomes something for us to think about. There is tremendous human capital in refugees. And the question I think for us is, how do we allow that capital to flourish so people can lead meaningful, substantial lives and contribute back to Canadian society? So one thing I should add is that although, I still think that Vietnamese migration has provided some of the most instructive information to those of us working with refugees. Really looking forward to data that's coming out around the Syrian migration, because we certainly will have similar type of results. We actually already do, but long-term results on a population, and I think Michaela will speak about that. So I'm going to speak to you a little bit about the demographics of refugee migration. Wanted to speak about some clinical issues, but in particular mental health and refugees. And then, of course, we'll speak about refugees in the COVID crisis. And then I'll finish by talking a little bit about health insurance for immigrants and refugees. So the first thing, of course, that we need to establish is that we're talking about the same population. What does it mean to be a refugee in the legal sense? And I draw your attention to this because, many times we'll hear on the media, you probably remember that earthquake in Haiti, where we started hearing in the media that we were expecting refugees to arrive from Haiti, or after the tsunami, there's talk of Sri Lankan refugees. So I just want to remind people that when we're talking about refugees, there is, although people have been seeking refuge from the beginning of time, really there's a formal legal definition of what it means to be a refugee. And that legal definition comes from a document developed after the Second World War. Remember, there were millions of people moving through Europe. The UN was founded. The UNHCR was eventually founded in 1951. They produced this document that's referred to as the Geneva Convention relating to the status of refugees. And to me, inherent in that definition is really three things. One, the person has to be fleeing persecution. So if your town is razed by an earthquake or a tsunami, that does not make you a refugee. If your kids are hungry, that does not make you a refugee. If your future is hopeless, that does not make you a refugee. You have to be fleeing persecution. And that persecution has to be for one of five things. It has to be for reasons of race, religion, nationality, membership of a particular social group, or political opinion. And I would argue that not all countries interpret those categories in the same way. So, for example, I would suggest that Canada has been a leader in recognizing persecution based on sexual orientation or on intimate partner violence. Not all countries will accept membership within a particular social group as broadly. So they got to be fleeing persecution. It's got to be for one of those five things, and you have to be outside your country of origin. So if you have fled Baghdad but are still in Iraq, that would make you an internally displaced person. If you've left Iraq completely, you'd be defined as a refugee. All right. So how are we doing globally in terms of refugee migration? Now, these numbers are from 2019. We're waiting for final 2020 numbers, but I can tell you in the first 6 months of 2020, these numbers did not change at all, which is not unexpected given what's happened in terms of border closures. So we are close to 80 million forcibly displaced people globally. 26 million of them are refugees. Close to 46 million are internally displaced people. There's over 4 million asylum seekers. And then a separate category the UN has developed is Venezuelans displaced abroad, which speaks to the millions and millions of Venezuelans that have left their country but may not have submitted a formal refugee claim. And there's over 3.5 million Venezuelans in that situation. Now, for the last 5 or 6 years, every time we do this talk and I pull up the slide, I'm always saying this is the highest number ever recorded. And every year it seems a little worse than the year before. So certainly the trajectory has been up over the last few years. All right, and where are refugees coming from? Perhaps no surprise, Syria has become the #1 source country for refugees. Remember, before the Syrian war, Syria was actually a refugee receiving country, right? So there are more than 1 million Iraqis in Baghdad alone. And as you go down the list, Venezuela, if you include that category of Venezuelans, then they would come in at second place. Afghanistan, which was #1 source country for years and years and years, there's over 2.7 million refugees from Afghanistan. As you go down the list, perhaps no surprises, South Sudan, Myanmar, and this would certainly speak to the Rohingya migration, Somalia, Democratic Republic of Congo, Sudan, Iraq, and Central African Republic. Now, where are people landing? Where do refugees go to? Well, many of us hear about the refugee crisis in Europe and in North America, but the reality is that close to 90% of refugees end up in adjacent countries, often less developed countries. So if you look at this list, the #1 country up here is Turkey, Colombia, which harbors over close to 2 million Venezuelans who've been displaced. Germany will make this list, and the United States makes this list only because the asylum seekers are included in this category. But really, the vast burden of refugee migration ends up on countries that don't necessarily have evolved infrastructures to be able to deal with such large numbers. So you'll see countries like Turkey, you'll see countries like Pakistan, where there's over 1 million Afghan refugees, Uganda, Sudan, Lebanon, Jordan would also be high up on the list. Iran is there as well. So something to remember that we hear a lot about how countries are overwhelmed by refugee migration in Europe and in the United States. But certainly the burden of refugee migration tends to be in the less developed world. What about Canada? So you'll see in 2020, there was 184,000 immigrants accepted to Canada. It was over 300,000 in 2019, not a surprise. When we look at economic immigrants, there was 104,000 that came last year, down from close to 200,000 the year before. Economic immigrants make up close to 60% of the immigrants coming to Canada. Now, one thing to remember is when you're looking at any data on immigration, it's going to be skewed by economic immigrants, right? And the vast majority of economic immigrants are people who come in under the point system, right? Multiple languages, multiple degrees, often have a job on arrival. In many ways, this really is some of the world's best educated and best trained for people. So, and remember, they always make up a majority of immigrants arriving here. Another quarter tends to be family sponsorship, and it was about the same last year. Close to 50,000 were sponsored by permanent residents here in Canada. Again, down from about 91,000 in 2019. When we look at refugee migration, there were 25,000 refugees accepted to Canada last year, and this is down from 48,000 in 2019. Canada, in terms of the total number of immigrants that we take here, about 10 to 12% usually, it was a little bit higher last year, 10 to 12% are refugees. So it's a very small number of the total number of immigrants. And then a very small number fits into another category, usually humanitarian compassionate applications. When we look at those refugees that come to Canada, it's important for us to realize that there's really different groups, there's different subcategories. So there's those that are resettled refugees, and I think the best way to speak to this distinction is resettled refugees are people who have been identified as people fleeing persecution before they come to Canada. So they're often processed by the United Nations High Commission for Refugees. They're held up to countries that will resettle refugees permanently, Canada being one. And when they're brought here, they're either government assisted or privately sponsored. Now, what does that mean? Government assisted refugees are people who are supported by the federal government. They're given access to settlement services. They're given a stipend, which is pretty much the equivalent of what you get on social assistance. And that support is usually for 1 year, in some cases 2 years, but for the vast majority, it's 1 year. Privately sponsored refugees speaks to a program that really was created after that Vietnamese migration in the early 80s. 5 of us could get together and decide to sponsor a refugee family. We'd be responsible for all of their costs, generally again for 1 year. So we would have to find them housing, winter clothes, pencils for the kids. It all falls on the sponsor. This tends to be historically, a number of faith-based groups that tend to do it repeatedly. With the Syrian migration, it was very different. There were a lot of new people that stepped up to sponsor Syrian refugees. And then so these are resettled refugees. When they land in Canada, they have their health card, they have permanent residency, they know that they're going to be here. Refugee claimants are a different group. So these are people who have found their way here to Canada. What does that mean? That means they come from a country where you don't need a visa, rare. They come with a visa, which we sometimes see. They sometimes come with fake documents, and the UN has clearly stated that people should not be punished for using fake documents if they're actually fleeing persecution. And the last few years, we've seen an increasing number of people crossing into Canada across the US-Canadian border. When they come, they make a refugee claim. They eventually will end up in front of a quasi-judicial body called the Immigration Refugee Board. If they're accepted, they're on the trajectory to becoming permanent residents. From the time people land to the time they actually get their hearing varies, but it has been historically around 18 months to 2 years, right? So you can imagine that period of time is a time of tremendous stress because people really don't know if they're going to be allowed to stay. So refugee claimants. And when we look at numbers, these are the 2019 numbers. About 50,000 people came and made a claim. 50,000 people were accepted into Canada. About 18,000 were refugee claimants, about 30,000 were resettled refugees. And when we take a look at this number, which is it's been relatively high for the last few years compared to where it's been historically. This is really driven by privately sponsored refugees. So we saw 20,000 privately sponsored refugees being accepted to Canada in 2019. And I think a large part of this is still that momentum that came from the Syrian migration in 2016. About 10,000 were government assisted. And this group is really a combination of the government assisted and privately sponsored, the blended visa office referred. All right, so it gives you a sense of the traditional numbers. What happened in 2020? Well, interestingly, there were a fair number of refugee claimants. Remember, we had 18,000 a year before, 16,000 last year. Why in the middle of a pandemic? Well, the reason is a lot of these people who were accepted had actually come in 2018 and 2019 and then had their cases heard in 2020 when they were accepted. What we did see was a dramatic drop in resettled refugees, right? So remember, this number was at 30,000. And this was dropped down to 14,000 last year. And a lot of these people would have come in the first couple of months, first 3 months before really the pandemic took hold. So, you know, as you can imagine, the resettled refugee system is really ground to a halt, not just in Canada, but across the world. When we look at group migration to Canada, I draw your attention to some events in history, right? So it was in the 1950s, Canada accepted 37,000 Hungarian refugees, 11,000 Czechoslovakian refugees in the 60s. In the 70s, 6,000 from Uganda, over 6,000 Somali Ugandans primarily, 7,000 Chileans in 1973, 74. And then we talked about the Vietnamese, Cambodian, Laotian migration, a smaller one in mid-1970s, and then that 60,000 that came at the end of that decade. In 1999, Canada accepted 7,000 Kosovars. And of course, you know, all of us remember that period in 2016 and the tremendous response by Canadians to that call out around the Syrian migration, where it really became an issue in the Canadian federal election in 2015, particularly after that photograph of that young boy on that beach in Turkey made its way across the world. So it was a tremendous response. For those of us that have been working with refugees for decades, I've got to say we've never seen anything like that. Right? Tim Hortons commercial, it was everywhere in 2016. Okay, so I want to shift gears a little bit and just talk about some clinical issues. And in particular, I want to focus on the mental health of refugees, because I think this is something that to me isn't intuitive and perhaps is poorly understood. I want to start by talking about the rates of PTSD in refugee populations. Now, I usually leave this up for a second to let people digest this. And you know, we hear all kinds of responses, and there's a lot of people tell us that this, you know, could be as high as 100%, given the trauma that so many refugees have gone through. So what is the rate of PTSD? Well, I draw your attention to this study. This is in the Journal of the American Medical Association. The study was done not long after the genocide in Rwanda, right? So Rwanda, I mean, some of the worst things that human beings can endure, some of the worst things that human beings can do to other people. When it comes to PTSD, we can always, you know, it's that issue where if you look for prevalence rates, you'll find studies that, you know, look at, say it's between 2%, and other studies that say it's 99% and everything in between. And there's a vast difference in methodology. Some people, you know, will do questionnaires, some people will do interviews, some people do it, you know, while folks have just left trauma, some people do it many years later. But if you pardon the methodology here, which was door to door, what was interesting about the study is a fairly large study, over 2,000 respondents, and no surprise, right? 3/4 were forced to flee their homes. 3/4 had a close member of their family killed, right? Rwanda. You know, 70% had property destroyed, and 25% met the criteria for PTSD. Now that's immense, right? At 25% over the course of a large population. But, you know, what struck me when I ran into the study many years ago was that 75% of people don't, right? So despite enduring that genocide and the absolute horrors that people lived through, 75% didn't meet the criteria for PTSD. Now, that doesn't mean that they weren't changed, that they, you know, the way they look at the world and relationships and issues of trust and, you know, weren't affected. But people weren't necessarily broken. And I think this for me is an important reminder, right? Is that not all refugees will be broken from their trauma. And so, what are the rates of PTSD? Well, it's likely 4 times higher than the general Canadian population. I think many of us feel it falls at around somewhere between 10 to 20%, although I remind you again that the studies really are all over the place, right? I want to share with you a bit of a confessional here. I'm going to share with you the mistakes I have made over the years dealing with the mental health of refugees, and hopefully this is instructive. So the first lesson I've learned, and look, I do this work, partly the medicine is interesting, but really because, there isn't a day that goes by where I don't hear these amazing stories, right? I've learned over the years to back off and not necessarily get into people's background, right? So, previous trauma has often been addressed. And so I've learned over the years to fight my natural inclination to ask when it's not really relevant, right? Not everyone is broken. And, sometimes people repress trauma, and that's an important coping mechanism, particularly when they first arrive. So, I think of one gentleman I saw. He was from Afghanistan. He had a very large family, 6 kids, and I got to know them really well. He'd had some issues, so we saw him quite frequently in his first year here. And, it's funny, if my door was open, his 6 kids would I remember one day, they just walked right in. They just sit, and I looked around, and there were 6 kids behind me. It felt like Julie Andrews in The Sound of Music. I knew this family really well. And it took this gentleman a year and a half to tell me that he would wake up every night, every 2 hours, screaming with nightmares. And he had been doing so for 20 years. And it's not that we didn't ask, but in that first year and a half, there were so many competing interests, right? He had to get settled, get the kids in school, this. It was not something that he was able to address early on. So I've learned to really let my patients guide me in terms of their history. There's many patients I know and I've known for years where I have no idea why they came, what happened pre-migration, because it really just hasn't been an issue. The second lesson, and this is sort of, a corollary of my first lesson, is not to underestimate the impact of post-migration stressors. I'll tell you another story. Another Afghan woman who came in, and she had these really vague symptoms. She had a headache when the wind was blowing outside, and often that's a sign that people are struggling with mental health issues. So I asked her, I said, listen, I don't know you very well, but I met many people from Afghanistan. I know people have lived through some very difficult things, and sometimes that can manifest in physical symptoms. And she was a very thoughtful woman. She, with the translator, she says, doctor, me and my husband, we came here. He was a physician. I was a school principal. We go every day to English classes, and we can't learn English. We come home, and nobody ever visits. And it was interesting because I was speaking about the war and everything that they must have endured. And she was quite clearly telling me that's not the issue. The issue is now. They needed a sense of self, a sense of contribution, the ability to have a community, all those, things that are very human. So, more and more I realized that not only in terms of determining who will struggle, but also determining how we can intervene in people's mental health struggles. Often it's about these social determinants of health. So you can imagine, for refugee claimants, there's so much uncertainty about their immigration status. For everyone, there's a loss of social status, right? Many of those people at those, those parking booths or, they're cleaners when we leave the building, we're very well established and respected in their countries of origin. Loss of family and concern about family left behind. That's often a very difficult issue, and that was particular issue for many of the Syrians we saw. Difficulties in adaptation and acculturation, language acquisition, and of course discrimination, right? And it's clearly been shown when people feel that they've been discriminated against, that is a risk factor for poor mental health outcomes. Okay, my third lesson, appreciate different manifestations of mental health issues at different points in the migration. So, for example, for many resettled refugees when they arrive, there's a tremendous period of euphoria, right? They've left what is sometimes a horrible situation. So when they come, they are excited. People are going to get a job. They're going to learn English. They're going to get used to winter eventually. And it's often later. And some people have actually studied this and looked at about 8 to 12 months later, where people realize, you know what? you've tried, you've looked around. Often it's hard for people to learn English. It can be very hard to get a job, that first job in particular. And of course, there's nothing good about winter. And so, with resettled refugees, those mental health issues will often present later. For refugee claimants, of course, their trauma, often it's not as remote as it is with resettled refugees who've had to wait a long time to be resettled to Canada. But really living in that limbo until they're accepted here produces tremendous stress. And we've had many, many people where they've done horribly. We've treated them as psychiatrists and counseling and this and that, and then they have their hearing, they're accepted, and everything is good, right? And quite understandable, right? All right. Lesson 4, of course, gender makes a huge difference. And it makes a huge difference pre-migration, where people sometimes don't have access to the same opportunities in terms of education and housing, and certainly post-migration, where women often take up the burden of child rearing, and thus they are confined to the home, might not have access to English language training classes. It was interesting, the work of Beiser with that mostly Vietnamese migration that I've spoken about. It was interesting. He found depression actually presented earlier in men and later in women. And the hypothesis was that men often enter the workforce earlier, where they're confronted with the challenges of language and loss of social status and low income wages and sometimes discrimination. And because women often had the burdens of child rearing, they were at home and entered the workforce later, where those challenges were confronted a bit further in their trajectory. And look, if I can leave you with one message, and this has been my obsession for the last 15 years, really what it should be about is connecting refugees to primary care early in their migration, even if they feel great. And this is a bit of a tough sell because, there's so many competing priorities, right? People have to figure out housing and, winter and get the kids in school. But over and over, we see that, if you're connected to someone, this is where there's an opportunity to then share when things don't go well in terms of your mental health, right? It's much more difficult if you're suffering for depression and then starting to look around for somebody you don't know to help you through that process. So, we've always argued that all refugees should be connected to primary care within the first month of arrival, which doesn't always happen. Okay, let's talk COVID, because how can we talk about anything without talking about COVID? How has COVID affected refugees? Well, certainly pre-migration. This isn't an area of my specialty, but we know borders have been sealed. So we know that so many people who are fleeing persecution will have even fewer options than they had before. And they weren't, for many people, there aren't a lot of options even pre-pandemic. Also, upon our arrival, what we're seeing is, remember from March till September, there were no refugee hearings taking place. So although there weren't people coming in big numbers, and there's always been a backlog of people awaiting their refugee hearings, we didn't make much of a dent in that backlog because the refugee system really shut down. Now, it started up again in September, October slowly, and now it's starting to move a little bit faster, but still people are waiting a year and a half, 2 years at least for refugee hearings. We have all heard about COVID affecting immigrant and refugees at much higher levels than other populations in terms of prevalence rates. And, this really speaks to high-risk employment and housing. In March and April, where so many people were able to tuck into their homes, we would call our patients, and it wouldn't be unusual for them to be on public transit, still going to factory jobs or working as PSWs. For those that couldn't find work, it's been a real challenge, and of course, there's limited employment opportunities. The social isolation has been horrible for so many people. I think it's been horrible for everyone, but for newly arrived refugees, they don't often have those support systems already in place to reach out to. So, often things like English classes and other settlement programs were the ways that they would develop community. And that's really shut down. So it's been immensely isolating. And of course, a lot of the support systems that were in place before are no longer at least available in person. So it's been a very, very difficult time for refugees that have arrived in the last year and a half here. I want to spend a moment talking about virtual care and refugees. And I've got to say, for the first 3 months, of course, like all of Canada, we've gone to mostly telephone and video calling. For the first 3 months, I loved it, right? I loved it because one, people didn't have to spend an hour on public transit in Toronto to get to us. They wouldn't have to spend the money, which is $3 to come, $3 to go back. Sometimes with kids, that becomes a significant amount. They didn't have to leave their jobs. They wouldn't have to find childcare. So, the first 3 months I thought fantastic. But, I've got to say some of the luster is gone. So, lots of issues we're finding. Access to hardware, that hasn't been a huge issue. It's amazing. I think one of the first things refugees do when they arrive, and this includes refugee claimants, is get connected to phones, because this is their ability to speak to family and people left behind. What has been an issue sometimes are data plans, just horrible internet. I was speaking to someone today, and I just couldn't hear him. We couldn't do a telephone appointment. We had to reschedule it just because of his access was so horrible. Privacy issues. We have many patients who have housemates. We have many patients who live in shelters where they have roommates, where they just can't speak about issues that may be very personal. Access to medical equipment. When we're trying to do more and more over virtual care. We're trying to avoid people having to sit on public transit to come and see us. There's some things we've been able to do quite well. Follow people with diabetes, because you can get them a machine at home to check their own sugars. Things like people with hypertension or high blood pressure. Those cuffs to check your blood pressure can cost $80 to $100, and they're not covered by insurance programs. And these are the kinds of things that I think we need to think about moving forward, because this really is an equity issue, right? Is that if we're going to talk about really the benefits of virtual care, and there's so many there, that we have to make sure that we give people access to the tools they need to be able to do their self-monitoring. Most importantly, though, I think the thing that many of us struggle with is that process of really connecting to our patients. And, when we work with refugees, it's everything, right? Trust is everything, right? This is how you get histories. This is how you make sure people come back to tend to their medical issues. I always tell our students the most important thing that we want to do on that first visit is make sure that people will come back for the second visit. So it's creating a sense of safety. It's being able to listen. And it's just really hard to do on the phone or virtually. So it has been a tremendous challenge, and these are issues we're trying to think of moving forward, because we know that even after the pandemic, there certainly are advantages to virtual care. I want to take a second to talk about COVID vaccinations. Draw your attention to an article that was in the Toronto Star about a month ago. It looked at the uptake of the COVID vaccine in public long-term care facilities in Toronto. And thankfully, the acceptance rate was over 90% in residents. But in staff, it was only 43%. Now, we know who those staff are. A lot of these people are new immigrants. These are racialized people, often working for very low wages. So why? So I think one, of course, there's been historically a mistrust in the healthcare system, often for good reason. And I say historically, I don't think you have to look back very far. At the beginning of the pandemic, there were many PSWs working in long-term care without access to PPE. We know the prevalence rates of COVID were so high in some of these marginalized communities, but yet testing was not nearly as accessible as other communities. And I think, people see this, and of course we lose trust. So, you have to be trustworthy before you get trust. And I think this is something that really needs to be understood. More and more, when we speak to our patients, they were telling us they were getting information from the internet. And some of it was really dubious. So we've made this a bit of an obsession in the last 2 months to try to get accurate information to people so they can make the right decisions for themselves when they're offered the vaccine. We've done a lot of webinars for shelters, shelter workers, for settlement workers and other agencies. This is a big problem, right? If one of the really high-risk groups out there is not getting the information that allows them to make the right decisions or their own correct decisions on taking the vaccine, it's a problem. All right, I'm going to just close by talking to you a little bit about health insurance, right? So do refugees have health insurance? I want to maybe start by taking you back now quite a few years. to a point where the previous federal government, the conservative government of Stephen Harper, made some dramatic cuts to refugee health insurance. And I won't get into the details, but except to tell you that it was a mess. It was not only, I think, was it very cruel, but it was so incredibly complex. And I remember the cuts were announced on a Wednesday. And I sent out an email to some colleagues, and I got a call back on Thursday from a guy who was the chief of family practice at St. Michael's Hospital, Philip Berger. Some of you may know him. And I didn't know him very well at that point, but he said, you know, this is horrible. And I said, yeah, Philip, this is really, it's going to be a disaster. And he said, well, listen, I've got this idea. And I said, what's the idea? He said, well, it worked in the 1970s. I thought, okay, great. And Philip's a bit older than me, right? Well, before the internet. And he said, here's what we're going to do. We're going to go occupy a federal government building. I thought, who is this, right? This sounded ludicrous. But the more I thought about it, the more I realized that this policy had come out. Obviously, refugees were not able to speak up themselves to challenge the government from which they were applying for refugee status. So in many ways, I think it fell upon healthcare workers to maybe amplify the messages we were hearing. So I just want to share with you this video, which, let me just put this in. Can hear this.
Yeah, okay. Thank you. I prefer to also be
Well, it seems fairly extraordinary to me that on behalf of the minister, you would not arrange a meeting not only with his constituents, but with physicians, many of whom are in different disciplines across the city, to discuss serious concerns. There's a proposition by the government right now that's going to deny many refugees coming here, some from camps directly, medications like insulin for diabetes. And if you look at this policy, it's really quite fantastic. Maybe I'll show it to you because you're not familiar with it. I mean, just listen to this. There's scenarios the federal government puts out. This is from Citizen Immigration Canada, so I'm not making up the document. And then for refugee claimants from countries not designated as refugee producing or rejected refugee claimants, there's sections here called medical emergency. Listen to this, doctors. Medical emergency dash heart attack. Then it says coverage provided based on client status. For heart attack, none. None for heart attack. How can that be in Canada in an official document? The federal government puts out a document that says if people having heart attacks, not going to provide medical coverage for them, or insulin for diabetics. If you can't come today, we'd appreciate a meeting. Maybe you could phone in. We can deliver our message to him, and then the meeting would be over. But you're not even going to permit a meeting to happen. So it's a bit frustrating for us.
Okay, doctors, you're going to have to go outside. The member of parliament's not here. So I've spoken to one of the organizers outside. It's okay to protest on the sidewalk. But inside the office, once the person wants you outside, you have to go outside, okay?
I just mentioned, as constituent, I'm disappointed that my MP has a policy that you won't, to instruct you not to contact him when I'm here to speak with him. I think that it's very, as a constituent, to discover that I can't ask you, that he won't take a phone call for you to let him know what's happening is very disappointing.
I appreciate that.
We do have a letter that we're going to leave with you on behalf of the organizing committee, on behalf of all of us, that you can deliver to Mr. Oliver with a contact phone number to arrange a follow-up meeting. Here it is.
Will you commit to deliver it to Mr.
I will deliver it to him.
Thank you.
Okay.
So that was in 2012, and it really led to a 4-year crusade with physicians across the country, right? Really from coast to coast. And it united a lot of us who work with refugees. And these are pictures from that day. And the media just loved it. This is the CBC, Toronto Star, CBC. And there was actually even an article in The Guardian in the UK that covered this. So where does it stand now? Well, look, all refugees are covered by a federal program called the Interim Federal Health Program, and the coverage is actually excellent. With that IFH certificate, you can see physicians, get diagnostic tests and laboratory tests, pretty much similar to what we get with our provincial health insurance. And you also will get access to supplemental services, which covers medications and emergency dental care, very similar to what people get on social assistance. So I'm going to close by just, with our take-home messages. One, global refugee migration is at record levels, and we say that every year. It's just going increasing year to year. As you know, COVID-19 has disproportionately affected immigrants and refugee populations. And, probably I think the most important message, that really all refugees should be connected to good primary care. I'll leave you with a couple of quotes. This one from Elie Wiesel, who was a Nobel laureate, but also survivor of the Nazi concentration camp. Today as yesterday, a nation is judged by its attitudes towards refugees. And then finally, a quote from Antonio Guterres, who's now Director General of the United Nations, but was the UN High Commissioner for Refugees for many years. While every refugee story is different and their anguish personal, they all share a common thread of uncommon courage, the courage not only to survive, but to persevere and rebuild their shattered lives. And really, no offense to anyone out there, but I always say I have the best job in the city. Not a day goes by where I don't see someone who's endured, often horrific trauma. But more often than not, when we see them, there's such a tremendous sense of resiliency, a desire to put their lives back together and contribute to Canadian society. Thank you very much.
And I think now, Dr. Arya, do you want to say a few words?
Oh, I'll just say a couple of words because we should move on to Dr. Henia's presentation. Thank you, Josephine, and thank you, Meb. There is a question or two in the chat, but we're going to try to save the questions till after Michaela's presentation because some of the things, including this thing around digital literacy, probably will involve both of our speakers. I'll just remind people that we will have another event in another 10 days on the Saturday. Our event will be part of a refugee workshop that students from McGill are running over 5 weeks on Saturdays. And we will be doing an event in French on migrants, primarily asylum seekers, but I'll talk more about that in closing. So Josephine, I'll leave you to introduce our second speaker.
Okay, thank you so much, Neil, and thank you, Dr. Rashid. So our next speaker is Dr. Michaela Henier. She's a professor in the Department of Psychology and Center for Refugee Studies at York University. Much of her work focuses on communities in situation of social conflict. She recently led a 5-year longitudinal study on the integration pathways and health among Syrian refugees in Canada, and is currently leading a study looking at the accessibility of virtual mental health care for refugee newcomers. So perfectly in line with the question about digital literacy. Dr. Henier is a past president of the Canadian Association for Refugee and Forced Migration Studies. We're really thrilled to hear from you today. Welcome, Dr. Henier.
Thank you very much. And Meb is always a tough act to follow. I'm basically just going to repeat his presentation now, but make it a lot less interesting by adding some numbers. So with apologies for repeating some of your work, but nobody's going to recognize it's the same thing. So I've been asked to speak about the social determinants of refugee health, and let me just share my screen so you can see my PowerPoint. Okay. And I'm going to start by just reminding people of what we mean when we talk about the social determinants of health. I then want to speak to the question of whether refugee health is different from immigrant health and in what way. I then want to address how experiences that are unique to forced migrants or that are more common among forced migrants can have implications for their health and well-being, with some data from some research that we have been conducting looking specifically at the social determinants of health for refugees. And finally, I want to try to apply this work to what's happening in COVID, looking at social determinants, particularly of mental health during COVID, for the sample of refugees that we have been following for the last 4 years. So there's a lot of different ways of thinking about the determinants of health, but one way of thinking about them is saying that one's health and well-being is influenced by our biological predispositions to particular illnesses or sensitivity to pathogens or environments, the accessibility and the appropriateness of medical care, the kinds of material conditions that we live in, including the presence of noxious characteristics in the environment, but also access to healthy things like food and fresh air and clean water, and also the social conditions that we live in, including experiences of discrimination or strong social networks. When we talk about the social determinants of health, we're actually talking about most of these determinants because they are all interconnected. And together, they also interact with our biological predisposition to influence health and well-being. I want to remind you that social determinants really refer to the groups that we end up belonging to as a result of social structures. So the world is structured so that people are categorized into groups that have varying levels of status and power. And with status and power come resources. So those social factors are things like institutions, educational institutions, medical institutions, the police, who create different hierarchies in society, class structures where people who are engaged in certain kinds of employment or certain livelihoods are in some classes relative to others. This is also, of course, determined by income. Social networks, which are the bonds or relationships that you form with people around you, where you support one another and can draw from one another various resources, including access to material resources and information, which might be a connection to a job, it might be information about how to get into university, and social norms that dictate which groups are stigmatized or excluded in society. So when we're speaking about the social determinants of health, we're talking about how these factors affect groups and how our membership in these groups then results in different outcomes for different groups. So one way of thinking about that is to look at how social structures shape our world to influence our access to resources and our power to influence our access to resources, and that this shapes our home and work conditions and our social interactions with others. In terms of work and home, it means that people who have more power, more status, and more resources tend to have more access to employment, better quality employment with less exposure to noxious substances or repetitive work environments or workplace injuries, more control over when we work and how we work. Those who have more power and more status have better living conditions. They have homes that are larger, cleaner, more access to fresh air, more access to parks, fresh fruits and vegetables. And so the impact of our work and home conditions affects our health and well-being directly because of the environment, but also indirectly because it creates opportunities for us to engage in health behaviors, or it makes it very difficult for us to engage in those health behaviors. It's difficult to sleep properly if you're working irregular shifts and if there's a lot of noise pollution. It is difficult to exercise if you live in a neighborhood where it is not safe to go outside and there are no nice places to walk. And it's hard to eat well if you have little time to actually access or create or cook food, and it's very difficult for you to access food in your neighborhood or fresh food in your neighborhood. It also affects our social interactions because it puts us in a situation where we can be exposed to discrimination or less control of our social interactions. And this has consequences for our psychological well-being. So too do our home and work conditions. So a key part of how the social determinants affect our health and well-being is through their psychological impact, particularly in terms of stress. High levels and constant levels of stress can result in physiological dysregulation, which can affect our immune system, cardiovascular system, metabolic system, and this can result in increased morbidity, increased mortality, and decreased well-being. It can also be associated with epigenetic changes. So even our genetic predisposition to have certain illnesses can be affected by our exposure to stress. So stress is a really key piece in how the social determinants of health affect our well-being. And it means that if you're tracking the impact of social determinants, you will often see that stress piece first, and then you will see those physical changes as a result of the perpetual stress or the toxic stress coming later. And the physicians in the room can explain that much better than I can. So if you have any questions about this, I direct you to Meb. Now, the healthy immigrant effect is one of the characteristics that people have pointed to talk about the social determinants of health and why they're important for people who migrate to Canada. In the Canadian context, immigrants typically arrive healthier than the average Canadian, and that health advantage decreases over time. Now, there are many different theories about why that happens, but there is evidence that suggests that what we are seeing here is exposure to negative social determinants. And the reason that we think that that's the case is first because the amount of deterioration we see is greater for those diseases that are most associated with poverty and stress. And the second reason is that the groups that are the most affected or show the greatest deterioration in their health after migration are those who are exposed to the greatest rates of discrimination and exclusion: visible minorities, those who have immigrated from non-European countries, and those who migrate in middle age. And I'm not saying that people who are middle-aged are necessarily more discriminated against, but rather when you migrate in middle age, you are typically migrating at a point when you are at a relatively successful part of your career. But reestablishing that status on arrival has proven to be extremely difficult for many immigrants. And so it's the relative drop in status that may be affecting people's health and well-being in this group. So how might that be different for people who have come to Canada as forced migrants rather than as voluntary migrants? Well, there's a number of reasons why it could be different. One is because of the pre-migration experiences that Meb has been alluding to, and I will speak briefly about them, but only briefly because Meb has touched on these. The actual experience of migration itself, so the migratory pathway or periods of time spent in asylum, and the kinds of experiences people have post-migration that may be influenced by those pre-migration experiences. So that could be one's overall health on arrival, the kinds of health conditions one arrives with, and the kinds of health determinants, social determinants of health that one has following arrival in Canada. In terms of pre-migration, I just want to repeat what Meb has already pointed, which is that if you are coming as a refugee, you are coming because you have experienced violence, conflict, persecution. We have seen the collapse of states. So that means infrastructure like the medical system, the educational system, access to running water, and lack of access to food and water is also one of the things that is very common. So you see malnutrition and you see very high levels of both material deprivation and social stress, as well as a lack of access to healthcare. The migratory pathway itself is very dangerous. So the exposure to elements through walking long distances or traveling across the ocean, as we have seen recently, is associated with a high risk of injury and even death. So in the last 5 years, the International Organization for Migration has reported at least 5,000 deaths for migrants in the process of migration. Studies that have looked at migrants traveling across Africa, both voluntary and forced migrants, have found that depending on which pathway they're on, between 1 and 2/3 report having experienced robbery, kidnapping, rape, or other forms of violence just on the migratory pathway itself. Once people arrive in the country of asylum, 60% of them or more now live in urban settings. But whether you're in an urban setting or living in a refugee camp, what we tend to see are poor sanitary conditions, a lack of clean running water, limited access to healthcare or healthcare that's only for urgent issues, particularly for those living in urban settings, the experience of discrimination and exclusion, and for most forced migrants, prolonged separation from family members and the people who matter, who can both provide resources and also social support. So here we see social stressors as well as material conditions and medical care all being affected by the process of migration or the process of being in asylum. I want to just pause for a moment to talk about detention, because detention of asylum seekers is of particular concern and has actually been increasing in some countries, most notably the United States. In Canada, we have not seen an increase in immigration detention, but we continue to detain people for immigration reasons. In 2020, almost 9,000 people were being held under immigration law. About a third of these were being held in prisons, along with people who had been convicted of criminal offenses, many of these including individuals with mental health conditions. And Canada has no maximum length of detention, so you can be kept there indefinitely. We also continue to see children being kept with their parents in detention to avoid separation. Detention is problematic because it has been associated with anxiety, depression, and PTSD, not only during detention, but also after people have been released. So we're talking about asylum seekers who have a legal right, according to international law, to be claiming asylum. People who've experienced trauma prior to migration actually see an increase in the impact and severity of their symptoms. And the longer people are kept in detention, the more severe these symptoms are. So the fact that we continue to keep people in detention in Canada is something that we should be concerned about. So what is the impact of pre-migration and migration-related factors on refugee health? Meb has talked about the fact that they can be arriving with risks to health, worse health conditions. They can come with a higher risk of specific infectious diseases like hepatitis and parasites. So you need to have a knowledgeable healthcare provider who knows what to look for and what to screen for. They can arrive with untreated injuries and conditions that may be much worse than they would have been if they had been treated on time. I also want to touch briefly on mental health, and I'm really repeating what Meb has said here, adding some additional numbers. And this is pointing to the fact that people do experience distress, and we do see an elevation of mental health conditions following exposure to emergencies, including the emergencies related to forced migration. We see double the rates of severe mental health outcomes, up to double the rates of mild to moderate mental health outcomes. And a very large proportion of people who've been exposed to these kinds of events show normal levels of distress. And I want to emphasize here that it is normal levels of distress. Like Meb, I also find the fact that there are so many different statistics around things like PTSD to be really problematic. One of the things that's worth thinking about is that many of these studies actually look at PTSD among individuals who are currently in refugee camps. So these are people who are living under very difficult conditions and people who have no certainty about their future. And there are many who argue that the most important piece socially, stress-wise, around forced migration is that you don't know what your future holds for you. So the consequences for people who resettle seem to be much better, or the outcomes seem to be much better. And in particular, what research with fairly large studies have shown is that about 80 to 85% of forced migrants recover with no intervention within or about a year or further after the event. But of course, it depends on the kinds of trauma they've been exposed to. People who have been exposed to torture or prolonged trauma will have worse outcomes. And this does not take away from the fact that we do see an elevation in all of these rates. So it's something that's important to consider. But to Meb's point, and one that I very strongly agree with, what we really should be thinking about also is that the vast majority are resilient, resistant, and have managed to get to Canada under really remarkable conditions. And that resilience and resourcefulness needs to be recognized. So how do those pre-migration conditions affect the post-migration situation? I will be drawing partly from this study and partly from other data. So I just want to quickly give you one slide that just says the data we're going to be talking about when we talk about Syria LTH focuses on Social Determinants of Health for Syrian Refugees Who Came Between 2015 and 2017. The sample represents 14% of all adult Syrian refugees who arrived in the Vancouver or Okanagan, Kitchener, Toronto, Windsor, or Montreal in that time period. And we rather remarkably have managed to retain about 86% of our sample over 4 years of data collection, in no small part because we have had an incredible team of peer researchers who have gone into people's homes and interviewed them face to face until this last year when we did it by phone. So let me start by talking about some population data, looking at education levels of migrants by migration class. This is people who came between 1980 and 2016. Remember that people who are living through a forced migration experience are also experiencing repeated interruptions to education and very limited access to educational opportunities. So not surprisingly, when we look at the average, or rather the percentage of refugees who are arriving with less than a secondary education, those percentages are quite high and very different from the economic migrants that Meb was talking about earlier. What is interesting is that they're not that dissimilar from what we see with family class migrants who are not being screened in the same way that economic migrants are. There are actually quite a few similarities between family migrants and refugee migrants, in part because of the private sponsorship model. With the exception of those large migration initiatives that we saw with the Syrians and initially with the Vietnamese, many people who come through the private sponsorship pathway are actually coming to join family members. So private sponsorship prior to the Syrian initiative was very much a family reunification exercise, with some people estimating that as many as 90 to 95% of people coming through private sponsorship were coming to join family members, even though they were being sponsored by faith-based organizations. So we see lower levels of education. We also see lower levels of English and French language ability. So again, this is immigrants coming into Canada between 1980 and 2016. And I want to draw your attention particularly to the yellow bar, which is the proportion who speak neither English nor French. And again, this is highest among refugee newcomers. And this is in part because they did not choose to migrate to Canada and have a chance to prepare for it, but rather because they were forced to leave their country, often with very little planning. And the country that they get to come to is not necessarily one of their choosing. So they don't have the opportunity to plan to go to a country where they already speak the language. Unlike economic migrants, where your fluency in English or French is one of the criteria in the points system. The other thing that happens for voluntary migrants that is different for involuntary migrants is that voluntary migrants tend to follow people they know. So people tend to migrate to places where they have social networks. Social networks are important because social networks are the ways in which you access a large number of resources. The social capital that you get from social networks is critical. This comes from the Syria LTH study, and it's just a quick look at what happens for refugees who are trying to find their first job. Most people find their first job through somebody they know. Refugees have fewer social networks when they arrive. In many cases, know nobody else here when they arrive. And how do they find their jobs? Like many of us, through their friendship networks. So the more limited your social network, the more limited your opportunities for accessing things like employment. And in fact, all three of the factors that I've just talked about, education, language, and social networks, have consequences for the other conditions of your life. So we've been talking about the fact that your previous experiences as a forced migrant include unmet healthcare needs, disrupted education, unplanned migration, and disrupted social networks. And this has consequences for higher rates of illness or disability, poorer language skills in the country in which you land, and less social support and fewer social resources that you can draw from. Those have consequences for example, caregiving responsibilities. So if there are family members who have chronic illness or a disability, there is greater responsibility for taking care of those family members that can intervene with the things that you would like to be doing to help yourself settle, like acquire the language and find employment. And all of these factors also play a role in and underemployment for refugee newcomers. This again comes from a study done by my PhD student, Jonathan Bridekirk, working with the Syria LTH team and the Syria LTH data. And it's looking at Syrian refugees who have now been in Canada for 2 to 3 years. And it's looking at their rates of employment. And it's also looking at what percentage of them are making more than minimum wage. Now, they're broken up into 3 groups based on education level. Those who have 9 years of education or less, so basically primary education, those who have at least some high school or some college or trade education, and those who have a university education or higher. That first bar represents employment, and the higher your level of education, the greater the likelihood of employment, although really it's just the difference really here between having some high school and just having primary school or very little education. But look at what happens when you look at income. People with a university education have no advantage in terms of making more than minimum wage relative to those who have less than 9 years of education. So people's preparation in terms of education is not translating into appropriate, rewarding, promising employment. And this is not just true for refugees, this is true for immigrants in general, but it is worse for refugees. So this is looking at data for people who came within the last 5 to 10 years. This is Canadian-wide data. It's looking at them by migration class, so whether they came as economic immigrants, family class immigrants, or refugee immigrants. And it is looking at whether this group of immigrants is living in chronic low income. It looks at 3 time points: people who have been in Canada for 5 to 10 years in 2000, people who have been in Canada for 5 to 10 years in 2006, and people who have been in Canada for 5 to 10 years in 2012. Now, one thing to notice is that the people who are living in chronic low income, which means 5 consecutive years of making less than what a family needs in order to buy what is considered the basic market basket for a family of 4, so who are unable to meet their needs. That proportion is decreasing with each cohort, if you will. But look at the proportion of economic class immigrants who have come in chosen by the Canadian government. 10% of them are still, in 2012, are still living for 5 years or longer in chronic poverty. And among refugees, that's about 15%. So the situation is worse for refugees than it is for other migrants, but it's bad for all migrants. And one of the things that people have argued around poverty and the push of people up out of poverty is that a lot of that is actually coming from child tax benefits rather than from improvements in employment situations. And poverty is associated with housing. So again, looking at the Syria LTH data, looking at people who had been in Canada for 2 to 3 years, we asked them about the quality of their housing. We said, are you satisfied with your housing? Is the community that you're living in safe? Do you have enough space for yourself? And is your house in good physical condition? And this is the proportion of people who disagreed or were neutral, neither agreed nor disagreed. About 34% were said they were not satisfied. About less than 15% said their community was not safe. Just with other research, we've seen that this number actually starts to increase the longer people have been in Canada, because it depends on what your expectations are. And for people who have come from a conflict zone, asking them if their neighborhood is safe, they're like, yeah, it's safe. If you ask them 10 years later, they're now comparing it to other neighborhoods in Toronto, and they say, no, this is a terrible neighborhood. So people actually perceive themselves as less safe the longer they've been here, because the comparator is changing. Do they have enough space? Not very many say they have enough space. And about a third say that their house is not in good condition. So those are examples of material hardships that are social determinants of health. What is the impact then on the health and well-being of refugee newcomers? Here I will once again turn to our data set and look at scores in the first year of our study. People have been here now on average 13 months. And we looked at their scores on the RAND-36, which is another scoring mechanism for the SF-36, a widely used measure for physical and mental health. And this is actually a standardized measure. And a score of 50 is the standard score for people from the United States. And as you can see, the average health of our sample is about on par with the average health of people in the United States. Now, I will add that at this point they've been here for 13 months, so any acute healthcare conditions have been addressed, and that there's enormous variability in here. We have people who have really difficult health conditions. But when you average it out, on average, they are doing better. Better than the average American, and about on par in terms of their, in terms of women. But we asked the question in another way. We asked them to rate how they felt about their health on average. So how good is your health on average? And what we found is that when we asked them about their physical health, we see that actually in year one, from year 1 to year 2, there's a drop in people's self-rated physical health from year 1 to year 2, both for women and for men, and then it kind of levels out. And frankly, it's not very positive. On a 5-point scale where 1 is poor and 5 is excellent, they're clustering towards the bottom. And oh, there it is again. Sorry, let me show you the mental health one as well. So we see the same pattern with mental health. So we see a drop in mental health from the first wave to the second wave, and then it levels out. One of our peer researchers summed it up by saying, when she came back from data collection, that what really struck her about the communities that she was speaking to is that they were more settled, but they had also lost hope. So there is this pervasive sense that things are not getting better, and not getting better at the rate that people had expected. We looked specifically at depression then in year 2, people who'd been here 2 to 3 years, and looked at what predicted whether they were experiencing moderate or severe depression. Not surprisingly, whether you were depressed in wave 1 predicted whether you were depressed in wave 2. But after that, we found some differences as a function of sponsorship, so that government-assisted refugees were more likely to report moderate depression than the privately sponsored. There was no difference for severe depression. People who had not yet learned to speak English and still relied on an interpreter, that predicted depression, both moderate and severe. People who were less satisfied with their housing, people who were not satisfied with their health care in their first year when they arrived, people who perceived less control over their lives, both in their first year and in their second year. And that perception of a loss of control or less control affected their depression levels in year 2 as well. And people who perceived less social support, which affected both moderate and severe depression. And then again, people who had been in Canada longer were more likely to be reporting symptoms of moderate depression than people who had been in Canada less than 2 years. Just to give you a sense of how many people we're talking about, in wave 2, we're talking about 18% of the sample reporting either moderate or severe depression, which is high. The last piece of social determinants of health I want to talk about are social determinants linked to the experience of COVID, because our last wave of data collection was occurring during COVID. So that changed things. And it was hard, as Meb says, it's hard to talk about any kind of health outcome right now and not talk about what's happening with COVID. So let me just give you, first of all, a quick look at what the rates of COVID testing and positivity were for our sample. So about 6.5% of the women and almost 10% of the men had been tested for COVID at this point. This is between July and October. 7% of the women and 9.9% of the men had tested positive. And just to give you a comparison for Ontario-wide data from work done by Astrid Gutman and her colleagues, they found positivity rates of about 10.4% for refugees, about 7.6% for immigrants. And for long-term or Canadian-born residents, it was 2.9%. So elevated risks of having a positive COVID test, but not as high as has been found in some other studies. We also asked our participants how much stress they were currently experiencing. And we found that about half of our participants reported moderate or high stress. And we asked whether that stress was due to COVID. And I think this is interesting that actually, no, mostly it was other things going on in their lives or somewhat COVID. So I will be talking about COVID, but I want to point out that the stress that people are experiencing, in many cases, they said, it's not about COVID. It's about what's happening with my family members. It's about separation from the people I care about. It's about employment. It's not about COVID. COVID did have an impact on their employment. So we saw lower levels of employment this year than we have in previous years, with about 42% of the men and 17% of the women employed. We asked people if they had lost their jobs because of COVID. 10% of the women said yes. 1 in 5 of the men had lost their job due to COVID. So again, to Meb's point, last one in, first one out. People are working in really vulnerable employment, and this has an impact on them. And we also asked whether their jobs were essential service jobs, and we defined that for them. And 41% of the women and almost 40% of the men said that yes, the work that they were doing was essential service work. And then finally, we asked them, have you had any difficulties due to COVID? And we asked them on a range of different factors. And I just want to point to a couple that I'm going to follow up now as important social determinants. One is concerns about meeting one's financial obligations, concerns with accessing food or getting access to food, cleaning supplies or PPE, which are face masks and other things that you need to do to protect yourself from COVID. And you can see that these rates are relatively high. 20% they said they had no concerns, but about 17% had financial concerns, 10% had concerns around food, around 13% about transportation, more than 25, I'd say this is 27% with cleaning supplies, and about 23% with personal protective equipment. What about difficulties in day-to-day life? Meb has identified this. Social isolation was the biggest concern for everybody, with over 50% of the sample saying that this is something that they're really having trouble with. So what are the impacts of these social conditions on refugee newcomers? So looking at what significantly predicts whether people had elevated stress, so here we combined moderate and severe stress. For those of you who want to know the percentages in each of the groups, I put them here, but that's a lot of data to look at. So we can return to it if you want to talk about it, but I really just want to focus on this column here, which simply indicates which of these things had an impact. So not surprisingly, people who are already stressed continue to be stressed. Men were more stressed than women, and they were more likely to have lost their jobs, so that's not surprising. People who still were struggling with English, so if you always needed an interpreter, you reported higher levels of stress than people who only needed an interpreter sometimes or never. Interestingly, having been tested for COVID was not a predictor. We had so few people who tested positive that we didn't even include that in this equation. Struggling to meet one's financial obligations, having difficulties getting food, struggling with social isolation. Not being able to get masks or other personal protective equipment didn't seem to be an issue as much. Having more people in the house. Size of the house, so crowding, apparently not. And age, which we thought would have an impact, also had no effect. So, are refugee health issues unique? Many of the experiences that refugees have to deal with are just more extreme examples of challenges faced by all newcomers, not having their credentials met, not having Canadian experience, not being able to access adequate, appropriate employment. But they also have different pre- and post-migration experiences that can create unique vulnerabilities, like those exposures to material hardships that may be quite different from what people who have come through the economic or family class may experience. Are those determinants social? Well, the kinds of social determinants that seem to be more prevalent among refugees are things like employment, the strength of their social networks, poverty, access to adequate housing. And what this indicates is that we need to do something about improving pathways to accessing these social determinants. And I just want to follow up on something that has been frequently said, which is that social determinants of health require social prescriptions. Don't just treat the symptoms, treat the cause. And that means making some difficult decisions about how we can actually improve access to these fundamental needs. And are these social determinants relevant for COVID? Yes. People who have vulnerable employment conditions, people who are struggling with financial challenges, people who already have a limited social network will be impacted by COVID to a greater extent. It is, in fact, a health equity issue. I just want to say thank you to the whole Syria LTH team, and there's many of them. I particularly want to thank John, Anna, and Toby, who helped me put together this presentation. And finally, I want to say that if you want more information about the project, we have all kinds of social media, which we don't maintain as well as we should, but we do have it, and we would be happy to answer any questions that you have. Thank you.
Thank you, Michaela. Yeah, wonderful presentation. I really appreciate how the two of you feed off of each other in this way. And I think that we've got experience from the clinical side, and we've got some questions around advocacy, and then with you with the research and policy and how you integrate that. But at the very heart of things is the care for people. We actually have quite a distinguished audience, as I can see, too, with health professionals from various domains, settlement workers, refugees themselves. And so I hope that they are a bit active in the chat. I know our time is supposed to be up now, but given this webinar type format, I think that we'll even have 15 or 20 minutes anyway, if the two of you aren't falling asleep. If people want to add more questions in the chat, but we'll start off with what's already there. So there was the question that is listed as being answered, but wasn't fully, and that was the digital literacy aspect. So if each of you could address that. A second set of comments and questions related to the advocacy, and Dr. Carol Herbert, who was the Dean of Medicine at Western, and also has written about advocacy many years ago in CMAJ, asked Meb because of, she was impressed seeing Philip there, so she wanted to ask about the role of doctors or health professionals as advocates and preparation of health professionals to be advocates. And then there were some other questions related to policy for improving the health and well-being, which I think both of you can address, but that may be directed more to Michaela. And then another person, an academic in Toronto, Donna Pavu, asked Meb, I think, about the University Health Network social prescription initiative, whether that reaches any of the vulnerable populations that we're looking at here. So a few questions for you to start off with, and hopefully we'll have a few others in the chat from people perhaps with lived experience or who are working with people in the settlement agencies and health professions. So why don't we get you to start off, Meb, and then Michaela.
Yeah, so I guess that first question in terms of training students, you know, I have to say that that response to the cuts to refugee health insurance, I mean, that advocacy work went on for 4 years. It went on, you know, every year we'd have a national day of action, and it would involve, I think at one point we had 21 cities, really going from St. John's to Victoria up to Iqaluit. And, you know, in many ways it was led by students, right? So, you know, each city we had physicians and nurses and other healthcare professionals who would in some ways lead, but really by the second or third year, it was students who would prepare it. They would do the social media piece. They would do some of the interviews. And, you know, I just had a colleague do a wonderful presentation today on how to embrace the social determinants of health in the healthcare sector. And I think, you know, part of what's so important is role modeling, right? Is that, you know, when it comes to our students, them watching us advocate for our populations, I think really resonates. So when the cuts were finally reversed, I think the quote that came to mind was that, you know, the Harper government has created a generation of healthcare workers who of students and healthcare workers who recognize now advocacy is a part of what is ingrained in our profession. So we thanked him for that. Right? So I think that's a big part. Listen, it's gotten much better since I graduated 25 years ago, right? I think students understand this is their role. How to cultivate it is something I think we're still working on. So yeah, with time. Main policy recommendation for improving the health and well-being of refugees. Michaela, do you want to take that?
Oh, thanks, Matt. Yeah, I think there's a couple of pieces to this. And one is that we have this bizarre expectation that people will arrive in Canada and a year later, they will have, maybe at the age of 30 or 40, learn to speak a completely different language, have their credentials recognized or updated, access employment, and moved on and be integrated. So I think one thing that we have to consider is think about whether, on what basis do we have this expectation that 1 year is long enough to provide support to individuals who are going through these fairly major transitions, and think about how we can better support them through those transitions. I think we need to really consider employment in particular, because there have been some wonderfully innovative employment opportunities that have united access to language learning with employment opportunities, but not just employment opportunities so that you can get them off of social assistance, but employment opportunities that actually lead to stable employment with an opportunity for progress and a career and a decent wage. The biggest issue for many of the jobs that people start off with is that they are jobs that will not build to other employment opportunities, that don't give them opportunities to build new skills or to connect to others and improve language ability, and that don't give them a living wage. So there's a cluster of issues around the health and well-being of refugees that I think also shine a light more generally on our social welfare system, which is that it is not adequate to protect people who are vulnerable, because it does keep them in poverty and prevent them from being able to exit out of poverty. That's why this is a difficult thing to address, because these are political questions. The other piece, and this is contentious, but that language classes, the people have been complaining about the quality of language learning that's available for refugees for years. And getting language skills that are appropriate to your education and appropriate to your needs and your age is critical to also supporting people through language learning. So making sure that that's also a possibility. So I think that some of these things are changes that are about how we do social assistance, how long we provide social assistance and social support to refugees. And more recently now, and Meb, I think you can speak to this as well, we're seeing more and more families coming in with really serious chronic illnesses and disabilities. And that impacts the entire family, because the family ends up having to help those individuals navigate their way through the system. And in some of our interviews with refugee newcomers who are in fact doing this family support, we'll have a 19 or 20-year-old who spends all of his time taking his mother with a serious disability from one healthcare provider to another, who gets kicked out of his language classes because if you miss a certain minimum number, you get thrown out regardless of why. And those appointments aren't flexible, who can't go back to school because he doesn't have the language skills, and is trapped in this position and is wondering why he came here. So we also need to think about how we help support people navigate these complex healthcare systems. And this is, again, difficult for all Canadians who are dealing with complex healthcare needs, but particularly difficult if you don't have access to the language and don't know the system.
Okay. Meb, did you want to add anything?
Yeah, I think I would just echo everything that was just said. There's such a brutality to living on social assistance in this province. I mean, to live on $700 in a city like Toronto, where it's just not possible. And most of our refugees will end up on social assistance because they, the fortunate ones who find low income work can navigate around that. But I think those types of supports are critical. If we want to take that human potential and make sure they thrive, we really need to invest in it. And I know that speaks to all Canadians who are living in low income. I think what makes refugees different is certainly the mental health issues and the fact that they don't have any of the social supports that other people have. But I think we've got to look at it as an investment.
So we have a couple of other things here. So one is actually a volunteer to help, and that's one thing about people who have been refugees or from the same country as refugees. So a pediatrician not working currently, asking if she can help as a volunteer. And you might want to address that, because we've had a number of great volunteers I know that each of us has worked with in different ways. But then the other question here relates to addressing social determinants of health within the context of culture and a variety of cultures and norms, and whether that impacts things, or I think we're going to say yes, it does, but how that impacts. So I think that both of those, each of you might want to say a few words about.
Mm-hmm. Did you want to go first, Matt?
Yeah, so I can just say with volunteers, I mean, our hospital does accept volunteers, but they really do make you do a dance. So there's an orientation, so it's been a bit frustrating at times. Saying that, there have been a lot of initiatives where we've been able to bring people with tremendous skills, some of them research, some of them advocacy. Although we don't have a formal program, it's a bit of a challenge. I do some work in a refugee shelter where we try to also incorporate volunteers. So, reach out and, it's also not a great time given the pandemic that, it's a bit of a struggle to get people into our hospital setting, but that can be a challenge. In terms of refugee social determinants, cultural views, look, culture cuts through everything, right? It cuts through how we speak to people, it cuts through, how different issues are manifested, but I think a lot of those social determinants are universal, right? When we're really talking about housing and employment and sense of self and having a community, I think it transcends all cultures, right? These are very universal human needs. This really is, in many ways what makes us human, right? We all want that. We want people around us. We want to be able to have support systems. We want to have some material, as Michaela eloquently pointed out. So absolutely, it does cut through everything. But, I think some of the issues that were raised today are things that speak to all refugees we see, regardless of where they come from.
I would just add that actually the plight of internationally trained physicians is particularly heartbreaking, because it is so difficult to make that transition back into one's profession. There are a number of organizations and groups that have been working with internationally trained physicians to try to help them find other opportunities for employment that is related to their field. There's a program, I believe, at Ryerson, and there's another group somewhere, and I'm trying to remember if I can remember who those individuals are that are organizing those groups, but there are definitely groups that are collaborating together to find opportunities to connect internationally trained physicians, which includes both immigrants and refugees, but it's particularly difficult for refugees who were forced to leave, often at the height of their career. It's a real issue, but there are groups that you can find who have who may be able to help connect you to volunteer opportunities or other opportunities. In terms of the cultural differences, I think one of the ways I think about integration is that integration is really about ensuring that individuals can reach their full potential. And that full potential is going to be different depending on the individual, different depending on their cultural background. And so one of the questions that we asked, for example, is, if you're not working, why are you not working? And a number of the women in our sample said, I don't want to be working right now. I'm a young mother. I have young children at home. I want to be at home with my children. And then we should be thinking about, how do we support families where the goal that they have here is to actually be present for their children and be able to support their children. It's recognizing that people are seeking different pathways to achieving a safe, secure, healthy, meaningful life. And it requires asking what they need in order to achieve those things, and then making sure that they have opportunities and they have choices. And the biggest challenge, I think, when one thinks about social determinants of health is the narrowing of opportunity and the limitation on one's choices. So if we can increase the number of choices that people have, then they will be able to address different needs and different interests. And that addresses many of these cultural differences that emerge.
Yeah, thank you. So in terms of volunteering, many of us have had international medical grads in our clinics helping with different things with interviews. The person at Ryerson was Shafi Bhuiyan, who is a physician from Bangladesh. So if you're in Toronto, we can get you in touch with him, but happy for you to contact us at the Pegasus Institute, or you could contact me, narya@uwaterloo.ca. I think that we will wrap things up here, given our time. Our next episode is March the 10th with Sir Andy Haynes. Dr. Haynes was the head of the London School of Hygiene, headed up a couple of Lancet commissions, and is speaking on health in the net zero economy, along with Dominique Souris. We don't have a title for her yet, but she's from the Youth Climate Lab and is actually interested in climate justice. So beyond that, there's an event that we're co-working on refugees with a group called CIM from Montreal, la Collaboration Interprofessionnelle Montréalaise Étudiante. Anyway, I will actually be speaking at their event to launch that on March in the morning, and that will be in English. They're having 5 weeks of presentations, primarily related to asylum seekers, but looking at various issues meant for an interprofessional student group. But we're going to have a Pegasus event at the end of the first day, from 11:40 till 1 o'clock or 1:10, and that will be a panel discussion in French, although we'll have a little bit of translation in English, but that will involve a physician, a psychologist from a group supporting people, an administrator, an academic who worked with refugees in Hamilton, and probably a refugee health professional. So a fairly interesting panel talking about various issues involved with refugees for those interested in this. So I hope that we see some of you at that event. We also have other events planned, workshops around lessons from Central Africa with regard to Ebola and how that relates to COVID in French. We'll have an event on migrants in Spanish with the US-Mexican border. So a lot of interesting events planned in the next couple of months for the Pegasus Institute. But we're now at the end of our time. So once again, I'll thank Josephine for moderating, and thank our 2 speakers, Meb and Michaela. Always fascinating. I've heard each of you several times, as has my wife Carolyn, and they just say that she just said to me, it's so wonderful how they speak and what they speak about, and I learn something new each time I hear from you, as I'm sure that many of our well-informed people in the audience have too. So thank you once again for giving up your evenings, because I know that basically both of you live and breathe refugees 24 hours a day, and are very generous with your time because of your commitment to things. So thank you both. Thank you for our audience, and hopefully we can look at different types of actions as people were talking about helping out. And in the meantime, it's nice to see things warming up in Eastern Canada a little bit. but still stay safe, stay connected as much as you can, and try to support each other. And thank you. Good night.
Thank you.
I don't know if Camille is still there to end things off.
Yeah, I can end it.
Yeah. So thank you on behalf of us again, Meb and Michaela, and
Oh, it's a pleasure.
we welcome any feedback that people have liked.
Thanks for inviting us.
Yeah,
it was
thank
great.
you.
And,
Have a great evening.
You too.
we've got
Bye,
two meetings
everyone.
in the next little while too with each of you. So we'll talk to you very soon.
Thank you,
All right,
Camille.
bye.
Thank you, Neil.
Bye-bye.
Thank you, Michaela. Thank you, Meb.
And
Bye,
thank you,
guys.
Camille
Thank
and
you.
Josephine.
Yeah, absolutely. Great
You're
job.
welcome.
Bye-bye.